So thank you all for being here. This presentation will be entitled Empowered Health, and we'll tell you why in just a moment. Thank you to the National Center for Farmworker Health, as well as the North Carolina Community Health Center Association and the Northwest Regional Primary Care Association for having us today, as well as the entire team that has been so supportive the whole time. My name is Mayumi Grigsby. I am an attorney and an advocate, and I consider myself a joyful warrior. I'm a proud graduate of Georgetown University. I keep saying that because we were heartbreakingly kicked out of the Sweet 16 much earlier than we all anticipated, and Northeastern University School of Law, and I work in policy here in Chicago. I want to give my partner in this presentation the opportunity to introduce herself. She's the Chief Officer of Strategy and Development at Friend Family Health Center here in Chicago. Wendy Thompson.
Thank you, Yumi. And I won't repeat everything you said, but ditto, I thank everyone who has worked so hard to pull this conference together. We're very excited to be here today. My name is Wendy Thompson. I am the Chief of Strategy and Development for Friend Health and FQHC, serving the South Side of Chicago. And so without further ado, I think we can just launch right into our presentation.
Great. So a bit of a roadmap of what we're going to do. We'll start out with our learning objectives. We'll go into why we entitled this Empowered Health, and then we'll talk about federally qualified health centers and end on a note of empowerment, I hope. So first, just to describe and lay out the landscapes and the objectives for today. First, we'll describe the landscape of health disparities based on characteristics such as race and gender. For this presentation, we are focusing on Black women. Next, we'll assess the impact of a lack of cultural competency on women of color and their access to care. And then finally, we'll establish the need for cultural competency and how federally qualified health centers can lead. Now, sometimes I talk too fast, so I will try to slow down. So first, you might be asking why an attorney who works in policy is here talking to you about health and specifically health equity. So I'll start out with my story. So back in 2018, I was an assistant state's attorney. I was relatively successful in my career. Everything was going really well, except for the fact that every once in a while, I found myself in debilitating pain. And it culminated in one night when the remote control was a little further away than I needed it to be. And in order to get to it, I found myself crawling on the floor to get to the remote control because I was in so much pain. So I knew that wasn't normal. I had great health care. So I went and checked in with my doctor, and my doctor told me everything was normal, everything was fine, and she saw nothing out of the ordinary. So knowing that it was not normal for me to be in that much pain on a regular basis, I did the thing that doctors tell you not to do. And I Googled my symptoms and went to WebMD directly. And then I found out that based on my demographic, based on the symptoms, that it was pretty clear what I had. It was fibroids. And so fibroids happens in 2/3 of all women. However, and these are non-cancerous tumors that occur in the uterus. They can be anywhere from the size of a pea to the size of a football. But when it happens in Black women, they tend to be diagnosed first 3 times more frequently as their white counterparts. They develop them earlier in life. They're usually larger, more numerous, and they cause more severe symptoms. So I like to say check, 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 and check in my situation. So I thought to myself, how is this possible that this could be something that I essentially ended up diagnosing myself, went to a specialist, and found out that in fact I was right the whole time, and that ultimately I had 30 fibroids that were growing inside of me that required immediate surgery to remove them. And the sad part was, obviously, I was not alone. So I want to talk a little bit about Kira Johnson's story. So Kira Johnson was a 39-year-old woman. She was married to Charles and the mother of Charles Jr. In April of 2016, she was in California, went for what she thought was a regular C-section. And for about 10 hours after the C-section, she found herself in unbearable pain. And as she's writhing in pain, her husband asks for help from the healthcare workers. And he's told, or allegedly he was told at one point, your wife just is not a priority right now. And so when they were finally able to put her on the operating table, they found out she had 3 liters of blood in her abdomen. So when what was supposed to be a routine C-section happened, the doctors had actually lacerated her bladder. And so she died on the operating table. Now, Kira's story is not unique. Before we go any further, I want to talk about some definitions. And I'm going to slow down a little bit because I do know that I went a little bit fast. So what we're talking about today is maternal mortality. And so maternal mortality is the death of a woman while pregnant or within 42 days of the termination of her pregnancy. That's important right now, especially since for a while the CDC had stopped tracking maternal mortality rates because of the fact that they felt like the information was incomplete or inconclusive. But they started doing it again, and we'll go into why that is important. Now, to go into the definition of federally qualified health centers, I will turn it over to my partner in this presentation, Wendy Thompson.
Great. So federally qualified health centers, a lot of people aren't familiar with them. And frankly, I will tell you that prior to beginning my work with Brent Health, I wasn't all too familiar. I passed this location several times and didn't know. I was familiar with sort of the concept of the city or the county clinic where people who didn't have insurance went. What I did not know is that federally qualified health centers are here to serve everyone. And that means that we provide comprehensive care. In most cases, that means medical, family medicine, internal medicine, OB-GYN, pediatrics, as well as dental and behavioral health, including substance use disorder. And it's our intent to provide that holistic care so that we improve health outcomes. While we serve everyone, we focus and target on the underserved, including the uninsured. We, in short order, we turn no one away. The message to all of our staff is someone comes in and they need care, we get them care and we figure out the details, on the back end. And when I say on the back end, I mean, if someone doesn't have insurance, we serve them, and then we also connect them to insurance options. There are many people who are eligible for Medicaid who don't recognize that, and that's what we do. And we do it pretty efficiently. On average, it costs 29% less to receive care at a federally qualified health center than at many other providers. I think I mentioned that we serve adults as well as serving children, whole families. In fact, we have multi-generations of families, but there also are some health centers that serve homeless. There are a specific community health center that's funded to serve the homeless, those that are there to serve the migrant community, and those that are there to serve the veteran community. We accept all of those patients as well. It just doesn't happen to be our specialty here in the city of Chicago. The key here, and then I'll hand this back to Yumi, is that we have a very stringent set of requirements. It is not just important to serve a large quantity of people. Our focus is to provide quality health care and be a patient-centered medical home for the individuals that we serve. And so when you mirror those two together, it puts us in an optimal position to address many of the health disparities that we find, particularly in rural and in urban environments. So.
Thank you so much, Wendy. And I think one of the things that you just said that is going to stick with us as we go on is everyone gets care, but it's not just everyone gets care, it's everyone gets quality care. So when we talk about maternal mortality in the United States, as I mentioned earlier, the CDC had stopped for a certain amount of time tracking the maternal mortality rate because of the fact that they felt that they were getting inconclusive or incomplete information. Well, even when they started to track it again, the news was not good. So compared to what are considered developed nations, the U.S. Rate of maternal mortality is 3 to 4 times higher than other developed nations. And what's even worse is that in other developed nations, while that rate is declining, in the U.S. that rate is increasing. So approximately 700 women die every year as a result of pregnancy-related complications, of pregnancy or pregnancy-related complications. And the CDC has mentioned that the majority of those deaths are preventable. So when we talk about Black women, specifically in the maternal mortality rate, it's important to note that nationally, Black women are 4 times more likely to die in childbirth than their white counterparts. In Illinois, where Wendy and I are, they are 6 times more likely to die than their white counterparts. And according to the Illinois Department of Public Health, just like the CDC and nationally, 72% of those deaths were preventable. You can't say that this is due to education or income or access to care, because if we think about the state that has the lowest maternal mortality rates, that's California. Even in California, Black women are still 3 or 4 times more likely to die due to pregnancy-related deaths than their white counterparts. So what does this actually mean, and what is the impact of this? So what's happening then is that Black Americans are experiencing some of the worst health outcomes. Black American women have the highest maternal mortality rates. Black American infants experience the highest infant mortality rates when compared to any other race. Black patients are spending less time with providers. So when we look at studies about what is the importance of cultural competency, we find study after study that says the outcomes are better when Black patients are taken care of by doctors who look like them. But what does that actually mean in practice? Because only 5% of active doctors are Black, and only 2% are Black women. So the other issue is then if we need the cultural competency and we don't have, and we also expect that, maybe it's due to the cultural competency that we have better outcomes when Black patients are taken care of by Black doctors or Black healthcare workers, then what can we do? Well, hopefully what that means is that we expand the access to cultural competency training, because we know that there are other effects, right? First, Black Americans are more likely to experience major depressive disorder, but then at the same time, they're less likely to receive treatment. There are other issues. This is costly. So available data suggests that the annual cost of maternal mortality amounts to billions every year. So an example of that is that in 2017, the cost of caring for mothers with preeclampsia exceeded $1 billion annually. And that was based on Medicare billing. And so that was in 2017 for only one root cause of pregnancy-related deaths. So what do I mean by empowered health? So as Wendy mentioned earlier, she talked about the stringent requirements that federally qualified health centers, I'm just going to say FQHCs, have to abide by. So they're community-based healthcare providers. Their funding is tied to a set of criteria. And one of the criteria is that their governing board is made up of 51% of patients. So now, because they're based in the community, that means 51% of those patients will also be based in their community. So then what happens now is that those community members that could be experiencing the worst health outcomes are now empowered to have a say in their care. They're empowered to give feedback on whether or not they've been dismissed, or they haven't been believed, or they haven't received quality care. And you might be wondering, what does this have to do in general with, say, migrant care or care affecting, other community groups that aren't Black women? Well, there is something called the curb cut effect that was the brainchild of someone called Angela Glover Blackwell. And so what the curb cut effect is she looks into transportation and public transportation, and how in making public transportation more accessible for the disabled, then what ended up happening is it improved the process, or they improved the experience for everyone else. So now you can take your stroller on the ramp. You can take your heavy suitcases on the ramp. So even though it was put there so that it could be more accessible, it ended up lifting up everybody. So the idea is, if you invest in one group, specifically a group that is experiencing the worst health outcomes, then essentially you're lifting up the care for everyone else. So that being said, I'm going to turn it over to my partner in this presentation, Wendy Thompson, to go more in depth around FQHCs.
Great, thank you. So I think on that last slide where Yumi, what are the methods, and you have the yes. Mm-hmm. Yes, I just wanted to really quickly point out a couple of things. Funding tied to a set of criteria. I do want to be transparent. Federally qualified health centers overwhelmingly receive the majority of their funding from the federal government. But with that, HRSA requires us to adhere to very stringent requirements and quality measures. And so at all times, while of course we need to be a sustainable organization, our goal is explicitly tied to the quality outcomes of those that we serve. And as we transition to value-based care, even more so, because in value-based care, you aren't compensated based upon the number of visits. You're compensated explicitly for the overall care and outcomes of the individuals in the community that you serve. Also, I wanted to just put out there a little bit more about the landscape and why this is so important, and why it's frankly why I'm passionate about the work that I do. I remember my son, he's 12 years old. When Chadwick Boseman passed, it just was it was a shock to everyone. And it provided such a good opportunity to talk about having a strong relationship with your primary care provider. And in many cases, that meant having a relationship with a primary care provider. And also to focus on the screenings, the relevant screenings at the relevant ages. And there's this concept, Dr. Robert Nguyen talks about big data and little data. When standards are set for screenings, they're set based upon the entire country, as they should. However, when you have disparate outcomes for different populations, it's important that someone is focusing on the outcomes of that population. And so more specifically, colorectal cancer. Up until very recently, 50 years old was the time that they suggested that your doctor would say it's time for you to have a colorectal cancer screening. Well, what we know to be true is that for African-American, particularly African-American males, they are afflicted with colon cancer as young as 35. So that is why the outcomes are that we have 20% so African-Americans are 20% more likely to get it. They get it earlier. And the net result is that there's a 40% chance that they're more likely to die. So that influenced greatly the reduction from 50 to 45. But as a provider serving primarily 90, I think personally for Friend Health, we're at 97% 7% African American and Latinx community that we serve. We have an even further stronger emphasis on ensuring that our population is screened, that we know what the family history is. Because if you have the power and you're empowered to know what your family history is and what that can mean, then that means that you can have the ability to change those statistics. So that's my soapbox, and that's kind of why I do this work. And I could tell the same story for breast cancer and several other cancers. So, Yumi, if you want to move on to the next section. So, as we mentioned, FQHCs are federally funded and highly regulated, and that's a great thing. And it helps keep everyone focused on serving the community. We serve all, but we target those that are underserved, and that includes the uninsured, the undocumented. When we select our service areas, we only go into the areas, we specifically define our service area and try to capture communities where there is a shortage of health workers, where there's a shortage of access. We want to create access. We want to reverse a lot of the disparities. So there's a lot of navigation and educational supports that we do for the communities we serve. And surprisingly, even though we're not as well known and maybe it's not as sexy as some of the other things that we hear about on the news, federally qualified health centers serve 30 million individuals across the country. With respect to the pandemic, we've been testing since March. I think that I probably work from home about as many times as I can count on my hand. We don't just stay in the confines of our building. We go out into the community. Since the start of COVID, we've established community-based testing sites. I will be going out to one of our hardest hit communities tomorrow on a block where individuals won't have access to public transportation to get to us. Even though the vaccine is free, we go to them. And that's just what we do. We know our populations, we know the challenges, and so we focus on ensuring that individuals understand. They understand their conditions, they understand if they don't have the conditions, how they can prevent it, and they understand how they can improve their own outcomes. Do you want to move on to the next slide? Okay, and so this slide here, when Yumi and I were talking about it, I was like, let's highlight really specifically how we do that, because we have MDs, we have nurse practitioners, we have nurses, we have MAs, but what are the things that make us a little unique and most suited to help address some of the challenges? It's diversity in hiring. And it's not to say that if you serve large populations of Black and Latinx that you only have to have Black and Latinx. That's not necessarily true. But what's important is that you have diversity and cultural competency in place. And those go hand in hand. So you have to have diversity. It's diversity of race, ethnicity, religion, socioeconomic background. Because when individuals come to us and they tell us that their stomach is aching, there are a myriad of issues that could drive that. Because what we know to be true is that what we do in the exam rooms represents about 15% of their care. And there are 85% of the things that happen outside of the exam room influence ultimately their health outcomes. So we don't have the luxury of just saying, well, we provide healthcare and that's the job of someone else. We ensure constantly that we are providing a diverse workforce. That's from the person greeting them to the care team to the providers. And there are times with the training where, we all come to the table with our own sets of biases and not with any malintent, that we have to circle back and just say, hey, this person was late because we're in the middle of a pandemic and the buses will pass people because they can only have so many people on at any given time. Well, if that's not your experience, if you don't have, if public transportation isn't a thing for you, it just might not be top of mind. Well, it's our job to ensure that our staff is aware of as many of the issues that our patients face, so that we can better serve them. Likewise, we have care coordinators. The healthcare system and certainly insurance can be extremely difficult to navigate. I often joke that it's almost like a part-time job, right? To go and, there are bills and then referrals and getting an appointment. And so sometimes, everybody needs a little help. Some individuals, like Yumi, will go WebMD, they'll get the information, they'll keep knocking on the door. And that is not necessarily the experience that others have had with large systems. A lot of populations, their experiences with large systems have been kind of like just a constant shut door. So at some point when someone says no, they take no for an answer. And what care coordinators are here to do, everything from translating what the doctors speak to patients, to reinforce, to encourage, to help them problem solve, to create access to resources. And ultimately, all of that is to empower. Additionally, community health workers. I spoke about the fact that what we do doesn't only happen in the confines of the walls. We go out into the community, we educate the community, not just our patients, but the community at large, because our patient represents a family, a community, and it's important that we share the love. Same thing with our outreach workers. They are constantly there. We do screenings in the community if there is a particular issue, whether it's high levels of or growing levels of HIV, if it's COVID, we go to where we're needed, we respond. And patient educators, can't say enough about the patient educators, just constantly sharing the knowledge. I learn a ton from them, but they are there to ensure that our patients understand, and they understand enough to ask the questions and that they're not afraid to. And I think those for us, those are the things that differentiate us as FQHCs, and allow us to provide culturally competent healthcare and to empower our patients. Yumi, I'm going to hand it back to you.
Thank you so much, Wendy. And that was amazing, because that takes us to where we are now. Wendy did bring up the pandemic, and we're in the middle of a global pandemic that is affecting everyone. But let's be clear, the numbers are showing that people of color are dying at a faster rate due to this pandemic, right? And so if there's already a culture of distrust or dismissiveness, something I did mention is that, Black patients are less likely to be believed when they complain of pain. They're more likely to be dismissed in emergency rooms. Sometimes they're seen as drug seeking. And so what do you do when you're in the middle of a global pandemic that's affecting all of us? And it's important to have that trust with your healthcare provider. So ultimately, I'm talking about the fact that right now in 2021, as we're talking about issues of equity, as we're talking about issues of inequality based on race, based on nationality, based on immigration status, now is the time to really make the changes that we need to make healthcare more inclusive, more accessible, and more culturally competent. So thank you all. We do have some guiding questions, but I do see that there are a lot of questions in the chat. So I'm going to stop sharing my screen so that we can address those questions. And I would invite everyone to please, if you can, and if you're in a place where you're able to, come off camera or come on camera, I think is what that means. Turn on your cameras, ultimately, so that we can have a discussion.
Great. So
that's Yumi. Let's see. I think folks really loved one of the the second to last slide that you just shared in terms of having cultural humility and the trainings. And so one of the questions that came into the chat was related to that, but it says, in addition to cultural competency, does your clinic require annual training related to cultural humility as well? Can y'all speak a little bit to that?
Sure. Yes. And I think that I have put them together just for simplicity's sake, but definitely cultural competency and the training that we provide includes that humility. And, there are a number of issues. It's based upon respect more than anything else. When you don't understand, and I think that's where we lead from. If you don't understand, don't assume. And that's just with religion, with ethnicity. Like, why would a patient do that? It's just listen. It's the power of listening to our patients. We learn so much when we just listen. What are you experiencing? How are you feeling? Sometimes there are mental health challenges going on, and mental health challenges can be, and I'm sorry, I'm not clinical by nature, so every now and then I just dabble and play with it, but just due to a particular circumstance that you're experiencing at that moment. And so that's why we do this on an annual basis, but there are times where we actually double back. We do patient surveys very regularly, and we try and have and present a care team model so that, a patient can find someone that they're connecting to. Obviously, we want them to have a strong relationship with their provider, but sometimes that might be the care coordinator where they're a little uncomfortable in asking their provider. They might ask the care coordinator, but we circle back as a team so that if that wasn't addressed at that point, or provides more clarity on how we can assist, we do it a little better next time. So yes, that was a long-winded answer to say humility, listening, not assuming, and come to it with a space of trying to better understand our patient. That is what we try to instill in all of our staff.
Great. So Wendy, it sounds like, do you all cover an area within that of internal bias? It's a question coming in the chat.
Oh yeah, definitely. And the recognition that we all do. We all come, and it's one of those things where it just is. It doesn't make, having an internal bias doesn't make you a racist, doesn't make you bigoted. It just means that you have lived a set of experiences that have formed and shaped your view of the world, right? And so through more experiences and more exposures, we can have a more full perspective, and working in a federally qualified health center allows a lot of individuals who may not have the same lived experiences to better understand what the needs of our patients are. And then I'll say one more thing, and then I'll stop talking because I talk a lot. But so our patients, our moms returning with new patients, with their babies, or with their young children. Sometimes they come in and we can just tell that the children may be suffering with some food insecurity challenges. And that's an issue of pride, right? And people have all sorts of trade-offs that they have to make, in deciding, do I pay the rent and ensure that we have a house over our head? Do I buy the prescription for grandma who, we want to be around? So once again, coming from the space of not judging. And so one of the things that we're doing is partnering with an organization called Love Fridge. I think they may just be Chicago based, but it's literally a fridge. And there are volunteers, organizations that come in and just put fresh food, fresh produce, put milk, put eggs, and they put food in the refrigerator, and it's kind of a community refrigerator. And so that way, if someone comes in to the health center, there's no judgment. You just, hey, I'm just kind of hungry, so I'm going to grab an apple. Or, hey, you know what? Well, we really don't have anything for dinner. There's not a huge discussion. You just go in and you get the items. And there's been such tremendous community support. And I think that comes out of listening to what your patient's needs are, respecting that everyone is trying to do their best, and then just trying to match the resources that are necessary, especially during this pandemic.
It's amazing. I love that. I want to give folks a chance to unmute, turn on your camera if you'd like to yep, go for it.
I have a question for Wendy. Can you hear me? Great.
Yes.
Okay, my name is Steve Nyman. I work for FQHC, Ample Health in Northern California. I was wondering, does your FQHC or clinics offer like a perinatal or prenatal programs? Are there any nearby? They do. And you had mentioned that the shortage of Black MDs. I would think that it would be kind of important if there were Black OBGYNs, and more so in the future, in the near future. So just your thoughts on that, both of you.
Do you want to dig in first, Yumi?
I'll dig into the importance of Black OBGYNs first, just to talk about the fact that, so one thing I didn't say in the presentation is that as part of my therapy to deal with all of this is that I wrote a book called Empowhered Health. And I talked to other women who had experienced similar issues. And one of the people I talked to was a woman named Dr. Vanessa Archil, who works and practices out here in Chicago. And she is a Black woman who is an OBGYN. And she talks about the fact that Black women will walk in and see her and go, "I'm so glad it's you." Sometimes they're moved to tears. Sometimes they want to hug her because they feel like here's somebody who's going to take care of me. And so I think that it is very important to have that representation. And even if you look, and especially, sorry, I'm looking in the chat at the same time, and I'll combine two things. One thing people talked about was the impact of stress over the maternal mortality and the importance of Black doulas. And so people don't know how fibroids develop, but they do think that it has to do with, it could be connected to stress and it could be connected to trauma. And so a lot of times people think of, there's some studies out there, they're trying to investigate that trauma, right? That trauma of racism or that trauma of implicit bias and what that's actually doing to us physically and what that's doing to, and how that's manifesting itself. So I'll answer that. And then also more and more people are using doulas, right? Because that doula, that doula is your advocate. So a lot of times when you're giving birth, I don't have any kids, but I've heard that you feel pretty vulnerable in that moment, right? You feel like just a smidge that you don't have a lot of control over what's going on. You're focusing on your baby, you're focusing on your life, you might be focusing on your partner. And so the doula gives that extra level of advocacy when maybe you feel like the healthcare providers aren't listening to you. So that's a couple of things that I just wanted to highlight, that need for representation and how it manifests itself in real life. And then I wanted to turn it over to Wendy to talk about, the programs.
Yeah, so we do. We're an FQHC that is located very close to an academic medical center, University of Chicago. And so we are very fortunate that our OB/GYN providers also can do labor and delivery for patients at the hospital, and we focus on trying our best to bring mothers into care during the first trimester. Doesn't always happen, and we get moms in third trimester, but it's. So I didn't talk about the demographics of our population. We're 48% children. And we're 40% women, of which a lot of them are OB/GYN patients in particular. So that's a sweet spot for us. We focus on it. And what I will say is that it's not important that every Black woman or every Latinx patient or any particular group has a provider that looks exactly like them. But what's important is that they have access to someone, so that if they do have that specific need for whatever the reason, they can make that connection, because wanting that, needing that, and not having access is highly problematic. And on a personal level, I will tell you that having a bright 12-year-old African-American male during these last 2 years it's been a rough time for our kids. When we talk, and they're aware of everything that's going on. And so everything from George Floyd to the protest, understanding his relationship with the police. And for the most part, he lives in a very diverse environment, school, just figuring out what does it mean to be an African-American male living in Chicago is rough. And so I tell you all of this to say, we determined that he wanted to talk to someone to try and help figure this out. But he was very clear that he wanted to talk to, a clinical psychologist who was an African-American male, because he felt like he had very specific issues that he didn't feel comfortable talking to someone. So did he specifically, for the quality of care, need to see someone? No, but is he going to have better outcomes because he feels more comfortable? He feels like that's what he needs at that moment? Yes. I hope that answers your question.
Yeah, thank you so much to both of you.
Thank you.
Gracias, colegas. Okay, let's see. Does anyone else have a question to ask? Feel free to unmute yourself or type it in the chat. One question that did come up too, Wendy, is when y'all were talking about like your outreach work that y'all are doing. You were talking about like the work y'all are doing with like peer navigators. Could you just speak a little bit more to that?
Yeah, so right now we have a community health worker apprentice program. So they've gone through a program through the city colleges whereby they have received, they've gone through coursework and achieved the community health worker designation. They come from the communities that we serve, just continuing to circle back to empowering the communities. And so we try our best to ensure that they're doing that work. It's been incredibly valuable during this pandemic because some neighborhoods, there's still a lot of distrust about the vaccine, about the test, even the stigma just around, I'm not going to be tested because that might impact my current housing situation. So if I'm feeling okay, we're just going to kind of go along with it. Having community health workers to debunk myths, one, they're viewed as credible because they're from the community, and they are most effective in helping us direct our resources. So we use community health workers and also always culturally competent. We have a community here called Gage Park, and they have had some of the persistently high levels of COVID positivity. And so in going out to do vaccines, we partnered with a number of the community-based organizations there and engaged the community health workers from that community who were able to immediately reach out and bring like 500 people in to be vaccinated. And that's like everything from, it's just everything that you talk about. It's not enough to just be bilingual. You have to be bicultural. It's essential. Understanding someone's experience and coming from a place where we're matching the right resources at the right time to the right people. It's an essential part of what we do.
And I just want to say, Wendy's being modest, but she's been an active participant from the onset of the pandemic and in doing that outreach and getting people to the, and meeting people where they are around testing and now vaccines. And one thing I want to say is, when we're talking about the outreach and we're talking about specifically the context of Chicago, in Chicago, where you live sometimes dictates or can give you a very good hint about what your race is, right? And so, by virtue of, Friend Health specifically being located on the south side of, further south in Chicago, that gives us access to a very specific community of African-American Chicagoans. And so, one of the things I'm going to steal from Wendy after this is it's not enough to be bilingual, but it's enough to be bicultural. One thing that people have been talking about around vaccines is about, African Americans not wanting to take this vaccine, or African Americans not taking COVID seriously. And I was thinking the other day about just my group of friends, and you can just sort of see the people who are actively looking for a vaccine and the people who are not. And a lot of us, I know about things like Tuskegee, the Tuskegee experiment, which, a lot of people are a little confused. So it was not that the US government gave African-American men syphilis. What they did was they led them to believe that they were being trained when in fact, they were being treated, when in fact they were being given a placebo. So for years they were gone. These effects of the syphilis was gone untreated. Another instance I talk about is with Henrietta Lacks, who had gone into Johns Hopkins medical facility looking for help. And there was a biopsy done on her cells. And then unbeknownst to her and her family at the onset, her cells were then used as the basis for all of these different, cures and medical advances. But at the same time, that's another instance of, historically, of African Americans feeling like they've been taken advantage of by not only the government, but also by, the healthcare industry. But that being said, now, when you talk to people and they say things like Tuskegee or they say Henrietta Lacks, some of them don't even know the context. It is stuff that they've heard from other people, but it's not always, every community is not a monolith, right? And that's why it's important to know what the reasons are for the vaccines. There are some people telling me that, it's for religious reasons. There are some people telling me, I don't believe all of them, but I do think that people have told me that it's for religious reasons, or it's because they don't want to take 2 shots, or it's because they don't know, or it's because they think, well, if everyone else is getting the vaccine, do I need to get the vaccine? There are lots of reasons for people being, quote unquote, vaccine resistant, even within, the African American community, which is why it's not just important to reflect the community that you're serving, but it's also important to understand that community. That was a little bit of a tangent, but
yeah, I think it's spot on. That's it.
Mm-hmm.
Yeah. Great.
Anyone have another question or comment? We have 9 minutes left. Robin, did you want to add something?
Yeah, I'm curious as to just understanding a little bit more about how preterm birth and maternal mortality kind of like intersect, and even like how stress kind of plays a part in that. And maybe on a different note, I'm curious if you've ever thought of using youth as community health workers. So yeah, those are my 2 questions.
So, I'll take my spin at it. I'll start with the last piece first. So 2 things. Our community health workers come into the program. They can come into the program as young as 18 years old, and there's no limit on age there. And I think that how we tend to deploy them, once again, we try and deploy them in the most appropriate manner. We know that there are some groups, some efforts where having someone that's under 25 is going to make the difference, but there are other cases where having someone who is more seasoned will provide the credibility. And just from now I'm going on a tangent, from a workforce perspective, it's a great entry into the health field. You are exposed to everything, and it equips you to determine where your interests are. And generally, if you're surrounded by a bunch of folks in medicine, everyone is very helpful and nurturing to support you in whether it's nursing or going back to school and even pursuing medicine as a doctor. You were asking about preterm and maternal mortality. So I'm going to defer to Yumi on the research here, but I'm just going to say that, anecdotally, what we know to be true is we crave having our pregnant moms initiate care with us during the first trimester, because that enables us to, if there are any behaviors and when in their nutrition, in their self-care that need to be addressed, we want to address those immediately, because those first 3 months are critical. They do matter in the development of the child, and also in what your experience is. The second trimester, you go through the happy period, and then the third term. So that's when we do a lot of the screenings, and we can figure out if there might be challenges, and so then putting plans in place. If we get moms later, we do our best, but that's when we find preeclampsia, that's when we find the most complications. And then because we haven't had the care all along, it's going back to this issue of knowing your patient. It's hard to know what's abnormal for this person. So I definitely think, there's a connection. Can I quantify it? If you give me some time to go back and get the data, which I'm sure Yumi already has. But yes, totally connected.
And I mean, I don't think it's completely conclusive to connect the stress with the maternal mortality rate, but I do think that it's important to talk about, social determinants of health, and talk about the fact that, there's more that goes into what constitutes health. And I think Wendy started to talk a little bit about that when she was talking about the fact that, it's about the community, right? It's about educating the whole person. It's about knowing what they're bringing in, to the table. And a conversation we had before about how, you're not going to focus on your health if you are food insecure, housing insecure. All of these things have an impact on your health. And I'm just going to say this, because I am not representing my actual employer right now. I, Mayumi, do believe that racism is a public health crisis. And this is something that a lot of people have talked about the impact of these images and what they're having, that impact they're having on our mental health, and that impact that they could be having on our actual physical health. And so I think that it's important to note that even if the, research is not as conclusive as we want it to be, so that we can, just definitively say that, I think we do need to start thinking holistically about health. We need to start thinking about what people are bringing into the hospital when they come into the hospital, and trying to treat that whole self versus kind of isolating everything. And so, one thing, I always go back to that story that I talked about myself and about my fibroids. I had 30 and nobody knew. And so if I had been in a place in my life where I wanted to have children, nobody would have explained to me that maybe that was why I wasn't, I wasn't able to conceive, or I wasn't able to carry that baby to term, because of the fact that, there was no room. My mother said that I had a whole village inside of me. I had grandparents and parents and children and pets. And so at the end of the day, I think that it's important to think holistically. And I think it's important to start looking at, as Wendy mentioned, that little data, and start looking at how that little data manifests itself in marginalized communities.
I think you just dropped the mic, Yumi.
I am going to, if it's okay with Wendy, I am going to share the last page of our slide, because it has our contact information on there. I know we only have about 8 minutes, so I don't know if Maribel, you have any announcements, but I do want to say, this has been amazing. I know I learned from presenting. I learned from Wendy, who I'm just so happy that she presented with me. I learn every time that we talk. So just wanted to say thank you again. And I will, and here's our information in case, anybody wants to follow up. Here is the information, and I'll leave it up there for a little bit. And then I know that there is another slide and another event, and you all have other things to do, but I want to give Wendy an opportunity as well to say some final words.
I just want to say thank you to everyone who spent time with us today, and just thank you so much, Yumi, for this opportunity. You are so forward thinking, and everyone get her book. She's great, and I'm just very grateful. So thank you very much.